thank you for an introduction, and then thank you for the opportunity to present our recent work and also learn from experts in the field. And then here's my disclosure. I have no financial disclosure, but I also want to disclose my research expertise is actually in MR imaging methodology instead of like a machine learning part. So as we all know, the COVID-19 is a global pandemic, just as yesterday night. So if there are over 4 million cases, confirmed cases around the world, and then around 300,000 cases of death. And then the key thing to, I think, to fight with this COVID-19 is how we can quickly identify which patient is positive, which patient is negative. So the current COVID-19 diagnosis is based on the virus test. So it's SARS-CoV-2. And the gold standard, as we all know, is based on the RT-PCR test. But we also know the RT-PCR, although they have very high sensitivity, which means if a positive, that means definitely positive maybe, but its false negative rate is also very high. So which means if a RT-PCR turns to be negative, you need multiple series tests to make sure it's real negative. And then another bottleneck for that is the current RT-PCR test takes some time to process. It's vary from several hours to up to several days. It depends on the process procedure. And then we all know the testing capacity is still a limit for the shortage of the supplies, especially in the outbreak regions like New York City. We still lack the testing capacities. And a lot of researchers are doing a lot of fantastic work on this field, like using the imaging, like chest CT or X-ray, can really play a very critical role in this diagnosis. And luckily, from our Sinai team, from when this outbreak in China, so we can get some data from our collaboration hospitals, and then actually we published several papers in radiology in back to early February. I think one of the papers is actually maybe the first research paper in radiologists. So when we interaction with the radiologist, when they analyze the data, we did find some interesting clinical questions to answer for those. So first, they definitely, I just want to mention, like chest CT imaging actually is not a primary like screening tool in US because the current is discouraged by the CDC. And then based on our radiologists, like the typical findings, so we all know the ground glass opacities. So it's very, very unique or a key feature for this COVID-19 positive cases. And then you can say that most of the time they have a bilateral, and no lung distributions. So like rounded morphologies. And also there's some, airspace consolidation, reticulation, and then crazy patterns, and then also reverse halo signs, the features. So, but we also know, so this imaging features is highly correlated with the duration of the infection. So in one of our paper published like in radiology, we found, so although we see a lot of imaging features, but if you check carefully about the early days, like early stages, in the first several days during the infection, actually like over 56% of patients, they show very normal chest CTs, which make the imaging analysis very tough or radiology very tough to understand whether this patient really is COVID positive or COVID negative. And then here's some cases I just want to share you guys. Say the left one is a 33-year-old woman with 2 days of fever, and then they have a clinical symptom like cough. But if you see the images, there's almost nowhere obvious imaging features. But the right one is a 57-year-old man with abdominal pain for 3 days. We can clearly see a lot of imaging features in the lower lung of that. Both of these cases positive. So if you give this in the left image to the radiologist, say is it positive or negative, they would definitely say it's maybe negative. And then this is another case about 58-year-old woman with 4 days, no fever, no symptoms, just feel tired. So from CT images, we can clearly see a lot of imaging features from that. So it's definitely from the RT-PCR positive. So what we really learned from these CT images, so we all definitely know the CT imaging have very unique features, which maybe can easily recognized by radiologists, but it's maybe for the mild or, not mild, like moderate or severe stages. Normal CT actually in early stage is very common in early stage of COVID-19 patients. So it comes to the question is, how can we really battle this, using the very initial CT, maybe they're only doing the first stage of the disease. So we all, based on the previous several talks, we all know AI is the role to find, have a great benefit to doing that. So some, learning feature from images. Also, we can transfer knowledge from the radiologist, deploy models, we're instant to get results. But our goal is try to not only using the pure images, but also combine with the clinical information to make a more comprehensive diagnosis. So this is our overall framework for the AI. So just I mentioned, we have image data from the full CT scans and also some non-image information. For example, the blood test from the lab, and then also some clinical symptoms like fever, cough with sputum, etc. And also exposed history, whether you have contact with some positive patient or you recent travel history. And then we just develop for all of this data, we actually evaluate 3 kind of models. First is pure using images to see whether we can get some information from that. And then the second thing is pure based on the clinical information using machine learning models. And then third is combine them together to get a joint model. And then the data set actually we collect from our collaborator, hospital in China back to early February. And then the total number is about 900, and then around 420 is positive, and then 486 is negative. But be very careful about this negative one. So just to mention, there's a lot of false negative. So our negative criteria is at least confirmed by multiple, RT-PCR tests and the clinical observation to make sure we try to rule out the false negative as much as we can. And then also the data we split to the standard like training, tuning, and the tested. But here we use the more data to test, like 30% data to test. And then the test set actually also read by the 2 radiologists in Mount Sinai. So one is very senior radiologist with over 10 years reading experience. The other one is a junior fellow, which is kind of, you just mimic the very reading experience to compare the performance with AI system. Here, the next I'll explain more detail about the models. So I just mentioned our imaging model, is based on the convolutional neural network models. So there are 2 major parts. The first part, we do the slide selection. So the reason we are doing that is we still due to the computation power and also limited features. So we decide to, based on the full 3D slices, to select the key features. So this is based on our pre-trained numerical tuberculous models, which is based on Inception ResNet version 2. And then this model actually we use this from our previous data. And then that one can achieve very, very high accuracy to differentiate the normal slices from abnormal slices. So we just direct using this, and then for our slide selection part. And then for the diagnosis part, we using based on the slide selected the CT slices and then segment slices, we run a ResNet 18 and we use 18-layer residual network as a disease and diagnose CNN. So this this network actually takes the images from just mentioned input and output the probability of the COVID-19 the probabilities. I just want to mention that we're using the maximum pool layer, output the log probability as a last layer.
我在主持一个网上论坛。
Okay. So the rationale of the design is that because given the normal finding is usually localized in the sub-region of CT images, we would like to predict whether a small region is abnormal due to this, COVID-19. We might not see a huge region of the like abnormal regions. And then for the clinical information part we just mentioned, actually we test several models. We test the SVM, random forest, multi-layer perception models. So we actually, based on some hyperparameter optimization, we decide to use the MLP model for that. So the detailed structure is the 3 fully connected layers, which each layer has 64 units for those, and then predict the probability of the COVID-19 part. And then here's come to some result for our data. So just you mentioned, so this shows what kind of clinical information we get from that. Just I want to mention, because this data coming from multiple centers from different regions, And then we just try to find like the most common, clinical information from all of the hospitals. So just like the standard, like sex, age, the temperature to know whether it's the fever or not fever, and then exposed history, and then the clinical symptoms, including the fever, cough with sputum, and the lab test findings, we including the white blood cells and natural polycytes, and then percentage of that, and then the lymphocytes. And then here's the AI model results. So just as we mentioned, we do actually 3 models. So you can see the joint model, the AUC curve is around 0.92. And then if you pure using the image model, this is about 0.86. And then if we only using the clinical information, is about 0.8. It's interesting, the senior radiologist, they can achieve the AUC around 0.84, but the junior fellow can only achieve 0.73. I want to highlight this part. This is because I just mentioned, for our data, we have another initial like CT scan with very normal CT. For example, there are 25 in the test set. There are 25 pure normal CT. Both the radiology cannot differentiate that. Say this also, they mentioned this is maybe COVID negative parts. It's interesting, like using either the model can still detect some of them. Like joint model can actually detect 17 out of 25 patients. And then here's some more like detail about the sensitivity and the specificity. So I have to say our sensitivity and specificity is not that high compared to the recent reported in like published AI papers. And then we can only achieve maybe 84% of those. I think this performance maybe can also be improved by using more advanced technologies or models proposed by the previous speakers. And then here's some examples of the chest CT images. I just want to show you guys. So all of them is COVID positive cases. So for some cases, as you can easily tell, like B and C, there's some key features, image features, which like radiology can differentiate those. But also I just mentioned some of them, like for the panel A, you can see very normal ones, but based on our property maps, we still can get some reasonable prediction for those. And then this is some diagnostic performance comparison between AI and the human readers. So we report accuracy, positive predict values, and then negative predict values. So you can see actually interesting thing is the accuracy is very similar with our performance is very similar with the senior radiologists, but the positive predict values actually we are way lower than the senior radiologists. But the good thing is we still have a reasonable higher negative predict values. So which means the model still need to be further improved. So in conclusion, so we just propose a generalized AI framework combining imaging and then clinical data, to make a rapid and comprehensive diagnosis of COVID-19. And then our model can achieve similar performance of senior radiologists, and then combine the models actually have some advantage to diagnose even early stage COVID-19 patient with normal CTs. But due to the limited sample size and then clinical information in study, so further tests definitely needed to improve the model robustness. So in the end, I still want to share some, because this work is actually done in the early February, in the middle of February. So since the pandemic also like outbreak in New York cities. So we actually, because our hospital is the one of the largest hospital in the New York hospital system. So a recent effort is try to build some COVID-19 registry, kind of like clean up the data, and also try to maybe clean and summarize the data to make it maybe available for more researchers to do that. So we try to collect all the clinical information and then images from clinical sites, and then massage the data to as a clean labels, and then put in the kind of like a cloud for different user to run their virtual machine to assess those data. I just want to give you guys some quick imaging data summary. So just I mentioned, in the United States, the chest CT is not widely used. So if you see the images, the majority of the data is still coming from the chest arrays. So in our hospital, over like 29,000 like chest arrays. but chest CT is maybe over several thousands. And then interestingly, also some of them MR studies, including multiple like organs. And then here's some more, detail about those. So this is the actual CT parts we can use. So we have like around, thousands levels of the positive and negative cases. And also some chest array and more data from chest array images. And then this is the MR part because I'm doing MR related research. So I'm more interested in this part. So you can see we have different organs like brain, abdomen, spine, different organs part, and both in positive and negative. And then PUI, which means we haven't decided in the system node which is positive and negative yet. And then the key thing I want to also mention is the clinical information. Just to mention in our previous work is we only use a small, very limited number of clinical information, but actually we have more comprehensive information from our hospital. So I just quickly summarize some of them. So you can see if the patient is in hospitalization, or you have more information from those like ICU flags, some lab tests, including also maybe ECG tests, ECG logins, multiple lab tests and diagnosis, and even vitals like the very key informations. So the question maybe for us is how really can combine this data as a big data and then combine with imaging to make more comprehensive diagnosis. So finally, I want to just acknowledge our collaborators, all the co-authors, and then here's some the QR code for the preprint for our paper in Nature Medicine. Thank you very much.